Kia ora koutou katoa. Nau te roro, nāku te roro ko ora ai te iwi. With my basket and your basket, the people will prosper. Ina mana, ina reo aora rakatira mā tēnā koutou, tēnā koutou katoa. To the members of the public in the university here in the College of Education Auditorium, welcome, and to those online, welcome. My name is Richard Blakey. I'm Deputy Vice-Chancellor for Research and Enterprise here at the University of Otago, and I'm just going to be very brief in welcoming Dr Ayesha Verrall onto campus and welcome her back to a place that she knows very well, and also thank her for all of her efforts before entering Parliament with us at Otago in helping to contribute to the efforts we've got to keep ourselves and our communities safe from COVID-19. And really just, it's been our great pleasure to have you back here and to reconnect you with some of your old haunts, but to show you some of the other things that we've got here. We're very pleased that you expressed a desire to give a public lecture while you're here, and I think there's people both in this audience and many people online who are really interested to hear what you want to say. So I will get out of the way and I will hand over to Professor Bob Hancock from the Department of Preventive and Social Medicine to give it a little bit more detail by way of introduction to you, Minister. But can you please join me in welcoming the Minister to the campus?
Kia ora koutou. I'm Bob Hancock. I'm the head of the Department of Preventive and Social Medicine, and I'm honoured to introduce the Honourable Dr Ayesha Verrall for this lecture. So each year, our department invites a distinguished guest to provide an open lecture on the state of public health. And it was sort of ironic in the biggest public health crisis of our time that last year we had to cancel the lecture. And we were far from confident that we were going to be able to hold a lecture this year. So we are delighted that the stars have aligned and we're able to host Dr Ayesha Verrall for this lecture this year. So Dr Verrall is very well known to many people in the university and in our department in particular. She studied medicine at the University of Otago, and while here as an undergraduate student made a huge impact, particularly with the Otago University Student Association, serving as the representative for the Health Sciences Division, the Women's Rights Officer, and eventually the President of the Student Association. She also had an instrumental role in founding the New Zealand Medical Student Journal. After graduating as a doctor, she undertook training as a specialist in infectious diseases, mainly based in Wellington and overseas, and practiced in Wellington as a specialist public health, a specialist infectious disease physician, but returned to Otago to undertake a PhD through our department. The PhD was studying in tuberculosis in Indonesia, and it's important to notice that even though she was studying a devastating disease in a disadvantaged population, she was really interested in what protected people from getting infected. In other words, she was taking a strengths-based approach to a debilitating disease. After completing a PhD, Dr Verrall continued to work as an infectious disease specialist and a senior lecturer at the University of Otago in Wellington, and then entered Parliament at the last election before becoming a minister. Dr Verrall holds a number of ministerial portfolios, including Minister for Food Safety, Minister for Seniors, Associate Minister for Research, Science and Innovation. But what is closest to our hearts, at least in our department, is the fact that she's Associate Minister for Health. She's played a very leading role in the response to COVID, but she's also been involved in many other public health initiatives, including water fluoridation, trying to prevent rheumatic heart disease, and proposals for a smoke-free Aotearoa. These have the potential to transform the health of New Zealanders. In particular, they promise to improve the health of some of the most disadvantaged people in our society. Dr Verrall, Ayesha, we are delighted to welcome you back, and we're very much looking forward to what you have to say.
Green light is on now. E nā mana, e nā reo, e nā iwi, tēnā koutou katoa. Ka huriki mana whenua o te rohi nei, tēnā koutou. He mihi hoki ki a tātou kua tai mai nei, I raro I te kaupapa o te rā. Nō reira, tēnā koutou katoa. It's a real pleasure to be back at the university today, and thank you, Richard and Bob, for that very warm welcome. And thank you, Richard, for hosting me today. I really value the chance to meet new and established researchers, and as we'll discuss, science-based policy is really important to me, so the chance to meet with your researchers has been very valuable. It's nice to see so many old friends in the audience too. I'd like to begin by acknowledging the many researchers and staff of the University of Otago who have contributed to the COVID-19 response. Recently, I know there are many of you, but some of the contributions that I'm aware of include, we've recently had epidemiologist Professor Trish Priest seconded to the Ministry of Health to assist us with COVID-19 modelling. We've benefited from the collaboration between Gemma Gergen and ESR on whole genome sequencing of COVID-19. And alongside that, Professor Murdoch, incoming Vice-Chancellor, and James Ushers and others have served on several technical advisory groups. I'm sure there are many others of you who have helped, and I'm very grateful for that. It's also a pleasure to be back on campus because for me, like so many New Zealanders, this university played a role in helping me become who I am. You may or may not want to take the credit for that. And while I'm sometimes still surprised to find myself in the role I'm currently in, if I think of myself as a former medical student and OUSA student president, then perhaps I should acknowledge there were clues that I might have ended up in the job in health politics that I'm currently in. And crucial to my readiness to enter Parliament and Cabinet during a pandemic was the rigorous training in medicine and epidemiology that I enjoyed here during my undergraduate and doctoral studies. So I'm immensely grateful for the teaching of epidemiologists like Professors Skegg, Dixon, Paul and Hill, from whom I developed a structured approach to disease prevention. So today I want to outline some of the initiatives that I've been involved with in the field of public health. And then I want to discuss the COVID-19 response and the transition in that response that we're currently going through. I'm most interested to reflect on what I think the lessons we should take from the public health response to COVID are. And finally, I want to discuss how we can embed these lessons in our reformed health system. So earlier this month, I was extremely proud to be part of the government passing the Health Fluoridation of Drinking Water Amendment Bill. I know Otago, as a leading a centre of dental education excellence, has played an important role in advocating for fluoridation. As many of you will know, evidence has shown that since the 1950s that fluoride prevents dental caries, and our country's oral health is poor. In 2019, 6,270 children under the age of 14 were admitted to hospital for operations for dental caries. I'm aware Otago has done excellent work in laying the evidence base for this. The bill entered Parliament in 2016 and, as originally drafted, sought to pass decision-making from local authorities to district health boards. One of my first decisions as Minister was to take the opportunity to amend the bill by supplementary order paper to instead have the Director-General of Health as the decision-maker rather than DHBs as proposed. This is a long-standing Labor policy and it is, in my view, a vast improvement. Community water fluoridation should not be a political decision, and we are only able to achieve equitable health outcomes if evidence-based public health decisions are not relitigated by a raft of different local authorities. Now, the Director-General of Health will make decisions about fluoridation of community drinking water supplies, potentially extending coverage from about 50% of community water supplies to more than 80%, and improving the oral health of tens of thousands of New Zealanders. From December, the Ministry of Health will be writing to water suppliers to gauge, among other things, their readiness to commence fluoridation and the Director-General will be able to make decisions or directions to fluoridate from mid-2022. As I've mentioned previously, we have some funds to assist local authorities with this transition, and I hope that local authorities in the southern region will take the opportunity to act quickly. Another area of progress has been the mandating of folate fortification of non-organic bread-making wheat flour. We know this vitamin is crucial to the healthy development of babies in early pregnancy, and often at a stage when even before the woman knows she's pregnant. Also, about half of pregnancies in New Zealand are unplanned, so it's not possible for all women to take folic acid supplementation 1 month before they conceive to reduce their risk individually of their baby developing a neural tube defect such as spina bifida. This is another public health measure for which the science was unequivocal. Yet New Zealand had opted out of a joint Australian-New Zealand food standard to mandate folate fortification in 2009. This followed a scare campaign led by the Food and Grocery Council, which forced then Minister Kate Wilkinson to abandon the proposal. Both folate and fluoridation are reminders that misinformation have been potent weapons against public health action in the past. That's why I approach my work on these issues very carefully. Our progress this term has been enabled by high-quality reports published by the Prime Minister's Chief Science Advisors on these topics, and also some good journalism, but also by the government's prioritisation of child well-being. Science is essential information to how we solve some of our most pressing problems, but how you act on that information is ultimately a matter of values and politics. Earlier this year, I announced a major upgrade of the breast cancer screening system and a new primary cervical screening test to help reduce the number of women dying from these diseases. Breast cancer touches the lives of many families in New Zealand, and I'm committed to ensuring New Zealand women can access the healthcare they need. The upgrade to the breast cancer screening register will ensure women aren't falling through the cracks by reaching out to the 271,000 women who are eligible to access breast cancer screening but are not currently screened, directly inviting them to get screened and running targeted campaigns. In other words, by moving from an opt-in to an opt-out register, we can improve the reach of breast cancer screening, particularly into Māori and Pacific communities. And while our cervical screening program has been a very effective tool for reducing cervical cancer, only about 65% of eligible wahine Māori access it because of the acceptability of the current smear test. Whakamā associated with the procedure is also another barrier, as is time and cost. I've been working on a budget bid for this issue for months when my friend and colleague in the Beehive, Minister Kiri Allen, told me that she was unwell. Sadly, it's these same barriers that led her to developing a stage 3 cervical cancer. It was with mixed feelings that I got the $100 million investment in these two programs across the line in the last budget. But now I'm proud to say we're funding an effective, simple and quick swab women can choose to do themselves, reducing barriers and making screening services more accessible, particularly for Māori and Pacific women. Again, information technology upgrades are an important enabler of this change. A new system will track a woman through the appropriate clinical pathway and generate an alert when a swab or an appointment is missed. And I'm pleased to say my friend Kiri is back at work in the Beehive in the office next to me, recovered, working hard, and always there to discuss a difficult problem or share a laugh late into the night. But throughout my first year in Parliament, the most acute public health issues have been those relating to COVID-19. And I want to reflect together on our experience to date. After the virus first appeared in China in late 2019 and began to spread rapidly around the world, it became clear that New Zealand's standard pandemic preparedness plan, based on influenza, would result in us missing an opportunity to control the disease. For me, this realisation followed the release of the World Health Organization Special Mission Report into the Wuhan outbreak on February 28, 2020. The report mentioned important differences between SARS-CoV and influenza, including a lower rate of asymptomatic disease and a longer incubation period, both important factors for the success of contact tracing. In late March, following the detection of cases in the community in New Zealand, the government introduced a new 4-level alert system to clearly indicate the current public health risk and the necessary measures required to protect New Zealanders and eliminate the virus from our shores. This approach evolved into New Zealand's elimination strategy, a sustained approach to keep it out, find it, and stamp it out. Our elimination strategy protected the majority of communities from the virus for more than 18 months, something that's evident in the relatively few hospitalisations and deaths here compared to overseas. From the start of the pandemic until the Auckland Delta outbreak this year, there were only 26 deaths in New Zealand out of 2,571 cases. New Zealanders enjoyed relative freedoms in the face of COVID-19, something that was rare globally, and as other jurisdictions faced lengthy lockdowns and high death rates with significant strain on the health system. I want to think about some of the reasons for that success, because the lessons are useful as we transition our COVID-19 response and as we restructure the health system. The first is about the role of science. The centrality of science to our COVID-19 response is undoubtedly a reason for the good outcomes that New Zealand has enjoyed. But what makes for successful incorporation of science into policy during a pandemic? Clearly, having a critical mass of technical expertise within our institutions, including the Ministry of Health, is important. And the Director-General has built that critical mass up over the course of the pandemic. And we have processes to capture insights from domestic experts, international posts, the science literature, and modelling. I've sought to strengthen these linkages through the announcement of a strategic scientific investment fund focused on infectious diseases. I've also worked with Minister Hipkins to commission advice from the Strategic Public Health Advisory Committee, chaired by Sir Professor David Skegg, and on which Professor Murdoch also serves. One of the challenges we face is being able to plan ahead in a dynamic environment. You will recall that this group's August advice was about safely reconnecting New Zealand. That began a work program that included developing methods to evaluate and manage risks posed by returning travellers, developing vaccine passports, and altering the duration and setting for quarantine. A key feature of the advice was that there would be 3 categories of return traveller, those from high, medium, and low-risk countries. It is that work that has enabled the phased reopening that Minister Hipkins announced on Wednesday. However, it is fair to say that every single aspect of our work on this program has changed. Most notably, the emergence of Delta around the world meant that the number of low-risk countries has become very small indeed. Another vital lesson from the pandemic is the need to build strong public health systems. In fact, we need to build strong public health systems as if our lives depended on them, because they do. That is what we have done with our contact tracing system. We have turned around decades of underinvestment in public health units and invested in the workforce. We built information systems that connected case and contact data across the country. This is a practical necessity to fight a rapidly spreading virus, and also because the devolved model of health protection services essentially meant that small public health units could not afford purpose-built information systems. The Ministry of Health has led the development of much better coordinated systems and protocols. We have developed a Telehealth Service, the National Contact Tracing Centre. You might call some of these changes centralisation. There is certainly greater coordination and leadership and provision of enabling resources like staff or information technology systems. But we continue to value the expertise of public health professionals who know their community well and are able to lead the response on the ground. Collectively, these measures have meant we've been able to contact trace at what I call an industrial scale. Remember when we traced 2,000 contacts of a single case when one traveller from Sydney visited Wellington in June. And in the early part of the August outbreak, we had 30,000 contacts under active management in the system. This is a marked change from the communicable diseases control system we had prior to the pandemic. Another area we have learnt lessons is the need to work hand in hand with communities using their local knowledge and expertise. That has really been highlighted by this pandemic. We've seen this in our vaccine rollout, where we have had to work carefully with communities to overcome barriers to access, but also to build up trust in a system, in a vaccine that has been subject to misinformation. Māori and Pacific health providers have been the stars of the vaccine rollout. They have been reaching out to whānau who we have traditionally underserved by door knocking, going to workplaces and places of worship, sports and recreation grounds to vaccinate people. We have learnt lessons on the way. Successful campaigns have focused on trusted faces and familiar spaces. We have also learnt that it's better to commission these services more directly now rather than going through DHBs. The spirit of these initiatives was perhaps best captured by Super Saturday. Somehow, the call out to community leaders, minor celebrities, MPs, and an earnest, cheesy 8-hour live television broadcast inspired over 2.5% of the population to get vaccinated in a single day. We unleashed the power of our aunties, principals, rugby coaches, and pastors to protect our people. These measures are making a difference. In a short time, the percentage of Māori vaccinated with their first dose increased from the mid-50% to 80% today. We are not where we want to be yet, but things are improving markedly. Meanwhile, Pacifica peoples are now vaccinated to almost the same level as the general population, at 90% for the first dose and 80% are fully vaccinated. My last lesson is we have mobilised all of government around a single health objective. A key element of this whole of government approach has been the standing up of the managed isolation and quarantine to form a defence at our border and to keep COVID out of the community. The MIQ system is led by the Ministry of Business, Innovation and Employment in collaboration with the Defence Force and a workforce provided by DHBs. While there is an understandable urge to remove the need for MIQ, it is important to remember that since March last year, with more than 189,000 people have been through our MIQ facilities, with 1,400 cases of COVID identified among them. The MIQ workforce, nurses, hotel staff, defence and security guards, cooks and cleaners, can claim a large share of the responsibility and the credit for the exceptional public health outcomes enjoyed during the pandemic. However, the tools that were effective against the original variant of COVID-19, including the world's most stringent lockdown, wide-scale testing and contact tracing, have not been as effective against the Delta variant. An R-value that is twice as high, a shorter incubation period, and a foothold in our most vulnerable communities has made Delta impossible to eliminate. So we're shifting from the strategic goal of elimination to minimisation and protection under the new COVID-19 protection framework, which will come into effect in this country in a week on December 3rd. The minimisation and protection goal, as articulated by the COVID-19 Strategic Public Health Advisory Group, sets the goal of minimising the presence of COVID-19 and protecting people and health systems from its impact. It is not mitigation or learning to live with it. It is perhaps closest to what other countries call tight suppression. Vaccination is the foundation of this new protection framework, colloquially known as the traffic light system. We have access to one of the world's most effective vaccines for COVID-19. So far, 84% of New Zealanders are fully vaccinated and 92% have had their first dose. Other countries, such as Israel and Singapore, have achieved high vaccination rates but see breakthrough infections. And we are ready in case the same happens here. We have already provided a third primary dose of the vaccine for people with lower immunity, and booster doses will be available in just a few days' time from those 6 months on from their first dose. Boosters are strongly recommended for anyone who's had their last dose six months ago, and vaccination clinics, pharmacies and GPs will provide them from the 29th. Children as young as 12 are able to be vaccinated against COVID-19, and our technical experts are currently advising on whether children aged 5 to 12 should also be vaccinated. We hope to have more information on this in the coming weeks. Vaccination remains our strongest and most effective form of protection, and we need as many workers as possible to be vaccinated, so sectors can respond in the pandemic and deliver everyday services with as little disruption as possible. So we have made it mandatory for workers to be vaccinated across the health and disability sector, our education, workforce, borders and corrections. We have also mandated vaccination of workers at businesses where customers need to show COVID-19 vaccination certificates in order to make those workplaces as safe as possible. We estimate 40% of our workforce will be covered by vaccine mandates. In addition, we've provided a legal framework to enable employers to work with their workforce to make decisions about requiring vaccination in other workplaces. And we enable all of these changes through the Vaccine Pass, which many of you, I hope, have already downloaded. The COVID protection framework is how we continue to mobilise all of government and therefore the community to respond to COVID-19 in our new system. The framework will enable us to move more freely than we have under the alert level system, with less disruption, and provides the stability many of us need to plan for the future. However, strong public health protections remain. I'm not aware of other countries whose plans for post-vaccine rollout include the ability to escalate public health restrictions like ours does. In fact, others just call their plans reopening plans or Freedom Day. We've learnt from other countries' reopenings and then seeing them being forced to re-implement restrictions, as is currently happening in Europe. We know that might be necessary, but it would not happen as abruptly as it previously did here under the alert level system. The COVID-19 protection framework builds on existing mask and record-keeping mandates. It places limits on gatherings in the situation that we need to protect the health system. It very clearly gives an extra nudge to those who need further encouragement for vaccination. I've been working with colleagues on the detailed guidance that underpins the framework that spans a number of industries. We are still mobilising all of the community around a public health goal. With the introduction of the framework, systems and processes which were designed for elimination now need to be adjusted to our new goals of minimising the spread of COVID-19 in the community and protecting those who are most vulnerable. That's why yesterday I announced an almost $1 billion investment to strengthen our testing and contact tracing system. We will boost laboratory PCR testing capacity across the country, reaching 60,000 daily tests in the first quarter of next year. And PCR testing will remain our preferred diagnostic test. We will expand the use of rapid antigen tests as screening tests for health workers, including in aged residential care and workplaces, and enable the public to purchase a rapid antigen test at a pharmacy and have the test conducted under supervision. We've also extended the funding for public health units who will focus their efforts on complex outbreaks that might occur in vulnerable communities or places where people are in close proximity. Their expertise and knowledge of their communities remain invaluable in our response, and we will take care to learn the lessons from the present outbreak of working with marginalised communities and to provide a service that integrates welfare, clinical and public health needs. The efforts of public health professionals and community providers will be complemented by further investment in telehealth services, boosting our contact tracing capacity and bringing in a new telehealth case investigation service. We are also developing a digital portal to enable a case to upload their own exposure events. This enables us to operate this public health system with a differentiated model, where those who are comfortable with technology, who have resources and relatively few needs, will be managed more efficiently but safely, and we're able to provide more intensive support to those who need it most. We continue to strengthen the public health response to COVID-19, and in doing so, are creating new models for future public health programs. So how do we build on the lessons learnt in the pandemic response as we restructure our health system? We need to strengthen public health expertise and structures to make scientific input into policy decisions more routine, continue to strengthen our public health systems, build on our ability to work with communities, and transition our whole of government pandemic response to strong systems for addressing the social determinants of health. The most important shift in the health reforms is reorientating the whole system towards achieving pai ora, healthy futures for all, so all people, their whānau and communities are supported to achieve their health and well-being aspirations. Overall, this signals a reorientation of the whole system towards population health and a greater focus on prevention of disease, harm and injury. This is the biggest change to the health system in a generation, and the difficulty and complexity of this challenge cannot be underestimated. With respect to strengthening expertise and institutions, the new Public Health Agency will be at the heart of the Ministry of Health and will be responsible for leading population and public health in partnership with the Māori Health Authority and the National Public Health Service. In particular, the Public Health Agency will lead population and public health strategy, policy, regulatory, technical specifications for public health programs, intelligence, surveillance and monitoring functions across the health system. We've seen the pivotal role of science in the COVID-19 response, and we want to make this approach of linking science and health much more routine and systematic. The strength of the new public health system will come from consolidating public health expertise and leadership and building strong connections with local communities. The Public Health Agency will develop a public health strategy and policy framework which will contribute to the New Zealand Health Plan. And this is so important because for so many important health issues, unless we have a plan, we are not able to confront them because many of them are long-term issues. This will incorporate a long-term view, recognising that to achieve pai ora and equity, we need to focus on the environments we live, work and play in, and important factors that often sit outside the health system that determine our health. A core foundation for the public health system will be a more fit-for-purpose knowledge and surveillance system to be led by the Public Health Agency. In particular, there will be a stronger focus on ensuring intelligence directly informs decisions and actions in a timely way. The system will draw both on the technical expertise of people in universities and local community expertise and knowledge. The system will bring together a broad range of data, scientific and public health data, as well as insights from engagements with communities and mātauranga Māori. This joined-up approach offers the best opportunity to help all New Zealanders to live longer, healthier lives. The Public Health Agency will provide secretarial support for a new Public Health Advisory Committee, which will play a critical role in the system. This committee will provide independent advice to ministers and will also help ensure early and effective response to public health issues. They will be expected to provide public health advice to the minister, which reflects the perspective of Māori and wider community views as well. The advice includes taking a systems-based approach to public health and to reporting annually on systems enablers, such as information systems, workforce and regulatory settings. The committee will be expected to prioritise equity-based approaches, including considering the factors underlying the health of people and communities. This will be an additional source of public health advice rather than replacing the Ministry's primary advice role, and the committee will be expected to consult the Director General, Director of Public Health and Director of the Public Health Agency on its annual work plan, as well as the Minister. An expression of interest will be shortly released seeking interested people wanting to be considered for membership of this important committee. As we have learnt through the COVID-19 response, collaborating with and supporting communities is also vital in order to achieve public health impact. We can achieve this in part through a locality model of care. Through the Health and Disability Systems reform, we want to see service provision at locality networks where different strands of healthcare are integrated, so New Zealanders can easily access support and treatment tailored for their needs. Focusing on localities centres our approach on the strengths of each community, including its iwi and community providers. It encourages siloed government programs to collaborate at the local level to meet the needs that are there. What would that look like? Well, take our vision for the Well-Child Tamariki Ora program. A review of this program found services across the early years should be strengthened to keep pace with the needs of whānau and be more integrated across health, maternity and social and early learning services. This could include simplifying the pathways for screening and early interventions and providing more responsive wraparound services. This is particularly important for some New Zealanders with the highest needs, including whānau with child care and protection issues or drug use. They are more likely to accept support if it is from someone familiar, and these types of models are already being tested, including through enhanced support pilots, otherwise known as nurse-family partnerships in Lakes and Counties Manukau DHBs. Soon I'll be releasing the Smoke-Free Aotearoa Action Plan, and similarly, through that I want to seek to empower communities to mobilise around a smoke-free goal. By working at the community level, we can change the environment so smokers feel better supported to quit, and we denormalise smoking so young people don't start. We will only achieve that goal if we enable Māori leadership of this work, and we will. But communities will also know that we have their back, and we will regulate to protect communities from the intrusive and harmful presence of big tobacco. In terms of building stronger public health systems, an important thing will be the development of a single public health unit within Health New Zealand, and reporting to the Director of Public Health in the Public Health Agency. This will build on the success we've had in the pandemic with having public health units work in a more coordinated way, while still respecting their strengths at a local level. They'll be supported by the Public Health Agency, which will convene our local expertise and national expertise for developing public health programs commissioned by Health New Zealand and the Māori Health Authority. The health reforms provide opportunities to more extensively take into consideration the social and economic determinants of health and well-being. And we must have a health in all policies approach. And we're almost there. We currently have a COVID in all policies approach. We have laid the foundations for this approach, and in fact, we did so before the pandemic. Minister Robertson has brought well-being to the core of our budget setting process, and last term, Minister Hipkins enabled cross-agency work through public sector reforms. This enables novel collaborations between agencies, like the joint venture that brings together officials to work on complex problems like preventing domestic violence. The Public Health Agency will be a focal point for this type of work across agency. However, we aren't waiting for the reforms to be complete. The government has an ambitious work plan on housing, and health officials are active to ensure that the housing we build is healthy, connected to services and to transport. We work collaboratively on the Prime Minister's Child and Youth Wellbeing Strategy, and we work closely with Minister Mahuta on the Three Waters reform, because until water entities are financially sustainable, they will never make the required investments in infrastructure to ensure drinking water is safe for all, no matter where they live. So in closing, we should be proud of what our pandemic response has achieved to date. And as we transition to a new approach to COVID-19, you can be assured that our confidence to protect people, our determination to protect people is as strong as ever. It is important that we continue to learn from our experiences and continuously improve in the pandemic response and as we reform the health system. We have a lot of work to do, but there are many opportunities, and I feel optimistic about our future. Ngā mihi nui kia koutou katoa.
Kia ora, Minister. It falls upon me to say a few words in vote of thanks. I know Professor Philip Hill would have liked to have been here to have done this as a former colleague and collaborator, but he's not able to be here. I have to say, in making these remarks, I'm a physicist, and so in terms of my approach to research, it's reductionist, and there is a place for reductionism to understand at its core what key issues are. And we will often say in physics, we would like to think of something in health as the patient being a sphere in a vacuum and looking at some of the root causes. But you have impressed me very much, and I'm sure the rest of our audience, with the with the understanding and the knowledge that to tackle real problems for real communities in areas such as public health, you need a broad spectrum of knowledge as an individual researcher and policymaker, but also you need to draw on a huge range of knowledges from different communities. Perhaps occasionally even physicists when it comes to testing and other strategies. I forgot to say in my introduction that you and other colleagues who were in the public communication around the pandemic in the early months were very reassuring to many of us in being a face that was able to communicate the research, the impacts, and then the potential futures to us in such an approachable and kind manner. And I think one of the things that I reflected on was the breadth of your love for scholarly matters extended into the arts and literature, with looking at the library behind you and many of that. And my wife, as student of English, would have looked dearly at your Margaret Atwood collection. I also note, look, that what we've heard today is the immense amount of effort that you have put in, and I would not be surprised if someone has found a way to clone people and there is more than one Ayesha Verrall, because the amount of work that you have demonstrated to us over a short period of time clearly can't be done by one person alone. And I think the multiple copies of some of the books in your library behind you indicates that there must be at least two Ayesha Verralls that each need a copy of the book. No, I joke, but honestly, seeing the work that you've presented here, and when I see a title talking about lessons learned from the COVID response, but that the first things you tell us are some of the other things in the A to Z of public health of fluorine and folate that you have managed to implement, tackle issues that have been of significant public interest in a manner that has got to a point of implementation, is truly impressive. We've then heard of the work that has been done under extreme pressure and duress, I'm sure with significant difficulty in decision making and guidance to help lead us through our elimination and into this new era of active management and suppression. And we do trust that the decision making will be sound, and that you will still lean on us as a research community for knowledge to help support decision making as needed. But then we didn't stop at, in the midst of a pandemic, we can focus on those issues. We also saw your vision and your drive and your commitment and your clear articulation of what our health system, and in particular the public health component of our health system, should be for the future, for ourselves as individuals, for our whānau and community, and actually for the national good. And so again, in that we thank you immensely, and through your inspiration, I think we'll all commit to being here to support you as needed. So on behalf of the audience here and online, can you please join me in thanking Ayesha for a wonderful talk to us.
Thank you very much. I'm very happy to take questions.
Now, Minister Verrall is happy to take questions. Now, I think for those on the online audience, I apologise, I don't believe we've set up a mechanism for relaying online questions, but I think we have quite a decent audience here today that will probably be able to ask some of the kind questions, and perhaps even some of the challenging questions that those online might be willing to engage with as well. Do we have any questions from the audience here? There's one up there. I'll run the microphone, and if you stay there, Minister.
Yeah, hi, Ayesha. It's quite a wide-ranging policy you've got going there. My name's Richard Seeger, and I'm just going to quote you something from John R. Sue, Vaccine Safety Team on the CDC, the Centre for Disease Control in the United States. And that is that they were expecting the number of cases of myopericarditis to be between 2 and 19 cases in the 12 to 24-year-old age range group. And they actually got 434 cases. That's a significant increase on what they were expecting. And it's across all age groups in that age group. So 12 to 15 is 143, 16 to 17 is 139, and 18 to 24 is 152. The risk for this age profile is very, very low. These are males, by the way. There's also females. They've had a lower incidence of those cases of myopericarditis. This would seem to, because the risk profile for these age groups are so low, they're literally at no risk whatsoever of getting COVID. Why are we even proceeding with a vaccine rollout for these age groups? Why? There's no reason.
Thank you very much for your question, and we take care to make sure that every part of the population, every group in the population that we roll the vaccine out to has a very thorough assessment by our medicines regulator, MedSafe, and also by technical experts. All of those data is constantly monitored by MedSafe. It is true that there is the risk of myocarditis does increase in younger age groups, particularly men, but it is, I think, not controversial that there is a much stronger benefit from vaccinating that group and protecting them from COVID than the risk of myocarditis. However, we make sure that we continue to monitor that, and we do so both domestically and keep up with the international data on that.
Kia ora, Minister, and there may be other expertise in the room that
Yes,
can help
indeed.
with that question after the Q&A. We have another question here.
So from your title, Lessons and Opportunities, so as a mental experiment, if we have everything the way for the next, case, next epidemic, if everything was the same, the technology, etc., the contact tracing, but we didn't know the nature of the organism and we didn't have any tests available to identify the positive cases, what would we do? Or, based on the last 2 years, what lessons should we attempt to explore and develop in our minds?
Oh, thank you. I had a discussion with some of the researchers in microbiology today about some of these issues. So, for a start, I'm told by researchers here that genomics is sufficiently advanced that we can develop sequencing technologies to characterise unknown pathogens. So I guess the response would begin with someone realising that they were dealing with someone with a clinician realising they had a patient who had a emerging infection that they couldn't yet diagnose, and we would need to have the facilities which we have in academia but not in our public health system to be able to sequence that. From there, as we saw in what happened in Wuhan, from having the sequence, it is possible then to start to make diagnostic tests, and indeed some of the scientists here at Otago were part of early efforts to do that here in New Zealand, and then the response starts again. I don't want to think much about the next pandemic because it just feels a bit much at the moment, but I think one thing to know about our current response is that if we have a new variant or something, another threat, we still have the alert level system, right? So if we don't have immunity to a new pathogen, we could use that. Now, we don't anticipate that we have to, and we're progressing with the traffic light framework because we feel, because we're have a highly vaccinated population, but we have those options.
If we haven't identified the positive cases, the alert system is just, if we can't identify the positive cases the way we have done on this occasion, the alert system, the contact tracing, surveillance, they'll prove of no use.
Yeah, so when I worked as an infectious diseases specialist, I guess there would be the types of types of cases where that does raise that question, and then that would send you down that path of sequencing and then developing tests for it. And they're the patients who clearly have an infectious syndrome, but you can't culture another, give another microbiological diagnosis for them.
Thank you, Minister. And my health and well-being is getting an advantage because I'm running up and down the stairs because people are deciding that questions are coming from diametrically opposed parts of the room.
Thank you very much. Thank you, Ayesha. We've trained a lot of people who've got a lot of expertise out of COVID, particularly in things like contact tracing. That we've upskilled a vast number of people. Just wonder if there are any plans to, when COVID eventually settles and fades and the contact tracing is no longer needed, are there any plans to use those skills into contact tracing for TB or sexually transmitted infections or other things like that?
Well, certainly, I hope we come out of this with just that extra strength in our human, in our workforce for managing other communicable and environmental health threats. So, you know, that's why we're making long-term investments, for example, in the public health workforce. Yes, we have trained an army of contact tracers, but also training some of those highly skilled people that we'll need in the future. I think another way of thinking about that question is the number of people who have been brought in as staff and Māori and Pacific providers. We are thinking about, in essence, what we are contracting for might be a workforce that we draw on beyond COVID. I know we've got a busy 3 years ahead to reach our smoke-free 2025 goal, to get our smoke-free rates down to 5%. And, you know, if we, the skills and community mobilisation that have been built up around, say, the vaccine rollout may carry through into some of that work we want to do in communities there. So I see scope for both the sort of professional and the community workforce to transition to some of our other programs.
I might just follow on there, and I think there's a question here, but I have to formulate it. I've also, as have some others of us, gone through personally the Christchurch earthquake, and we're seeing that in the COVID response, things like the Student Volunteer Army coming up, and I guess we've developed our own form of national service that has standing cohorts of people who are able to, when the need comes, and we don't know what, it might be a public health, it might be a natural disaster, there might be some other thing that's over the horizon, but I think we can have confidence that we've got communities that are prepared to lay down what they're doing and focus their effort, and then we've just got to build capacity in that sort of standing public service and public duty. Is there anything more structurally we might need to do around that?
I was really, it's interesting you mentioned the Christchurch earthquake, because I was very impressed when I visited the public health unit in Canterbury DHB at the range of relationships that public health unit had built with iwi, with community organisations, with vulnerable communities, with local government, following from the Christchurch earthquake. And as a result, they weren't doing that work for the first time when COVID struck. So that was a very impressive group, and I think it's those sorts of relationships that would focus on more when we bring that locality approach to health service planning.
And I should say the other point I meant to note in my vote of thanks when you talked about activating communities was understanding from what's happening here of Te Kaika as a model as well, the village that's community driven, it is Runaka led, and it's a partnership model, and it's delivering health and other services. And I was just in Vikago Morihiku yesterday, and that delivery of career advice and training and being integrated in those community services that we provide, I think offers huge opportunity. Anyway, we are approaching the time where a minister has to get into a vehicle to get to the Dunedin airport to get back to busy work in Wellington. We know how much effort you put in, Minister. So if there are no further questions, can you please all in the room join me again in thanking Minister Verrall for that very, very inspirational talk. Thank you.
Thank you. Thanks, Richard.